Thank you, operator, and thank you for joining us for the COVID-19 daily media call for May 15th. Governor Walz is not on today's call. We'll be starting with a situation report from Commissioner Jan Malcolm. Following that, we'll get an update from our state epidemiologist, Dr. Ruth LYNFIELD. Following Ruth, we'll get an update from MDH Infectious Disease Division Director Chris EHRESMANN. After those opening updates, we'll open it up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thank you, Mike, and good afternoon, everyone. Quick data brief again. Globally, as of this morning, we were at more than 4.4 million cases and 302,000 deaths. In the United States, as of this morning, we were just over 1.4 million cases and 85,000 deaths. In Minnesota, we have a new total of 14,240 cases, which is up 808 cases from the prior day. That is our single largest day-over-day increase. Despite that high number of new cases, we still are at a 12-day doubling rate for total number of cases, which is an improvement over last week. And unfortunately, we lost 20 additional Minnesotans to COVID-19 from yesterday. We had, among these deaths, 8 in Hennepin County, 5 in Ramsey, 3 in Anoka, 2 in Itasca, 1 each in Carver and Dakota. This total includes 1 person over the age of 100, 3 in their 90s, 10 in their 80s, 1 in their 70s, 4 in their 60s, and 1 in their 50s. 17 of these individuals were residents of long-term care facilities. I'd like to take a moment also to call your attention to an order that Governor Walz just released shortly ago. He has directed that all flags at state and federal buildings in Minnesota will be flown at half staff from sunrise to sunset on the 19th of every month through 2020, starting with next Tuesday, May 19th. To remember and mourn and honor all the lives lost to COVID-19. I think it's a wonderful way to remind us that these are not just numbers. Going through these numbers every day, one can almost become numb to the fact that they represent, every one of them, a loved one and a family member and a neighbor. So I thank the governor for that acknowledgement and that way of reminding us all how serious this outbreak is and what the stakes are for all of us to continue to be part of the effort statewide to keep these numbers as low as we can. There are 498 patients currently in the hospital, which is a net change of 0 from yesterday. 3 fewer people in intensive care. So that net 0. I would like to also just make mention of the fact that we had our second highest testing day yesterday. So we had 808 new cases on a testing volume of just under 6,000, 5,890 to be specific. Lower than the day prior, but still our second highest testing day. Again, we want to remind Minnesotans that people who have symptoms of COVID-19 can and should be getting tested. And again, that basic message, when you test positive and or if you even feel sick and before you're able to get a test, please self-isolate. That means staying at home. Nothing about the new stay safe messaging means that we should be out and about when we're ill. Staying home when we're sick is a fundamental part of our Stay Safe Minnesota strategy. With that, I would like to turn it over to Dr. Ruth LYNFIELD for an update on a Health Alert Network message that was just issued this morning. Ruth.
Thank you very much, Commissioner. We sent a Health Alert message out about a new condition that was originally recognized in Europe and then in New York, and now is being seen in other geographic areas. This is the multi-system inflammatory syndrome in children. And we do think that there may be a connection with SARS-CoV-2. We sent the health alert out because we have heard that there may be some cases in Minnesota, and we would like to get the reports and be able to find out if it is occurring and how frequently it is occurring. This is a syndrome that children have presented with fever. They have presented with signs of inflammation. Many of them have had abdominal pain, diarrhea, or vomiting. Many of them have had manifestations that are very similar to a syndrome called Kawasaki's disease, in which there can be red cracked lips or red tongue. There can be a rash. There may be swollen hands and feet. There can be red or pink eyes. And what people have been noticing with these children, however, is that some of them are getting very severely ill. That's the multi-system component, where they have more than 2 organs having evidence of having involvement. And many of them have had heart involvement, but also kidney, lungs, blood, the gastrointestinal tract, neurological manifestations, and I did mention rash. Some of these children are positive by PCR for SARS-CoV-2, the virus that causes COVID-19. Some of them are not positive, but when a blood test was done to look for exposure to this virus, they were found to have antibody to the virus consistent with exposure. So we are learning more about some of the complications that may be occurring. And so we need to look into this more, but certainly in some children there has been this connection. Other children have had family members who a number of weeks prior were ill, or they were ill. And so in some children it seems to present a number of weeks or even later than symptoms that are consistent with COVID-19. And again, many of them have had gastrointestinal symptoms. So we are asking clinicians and parents to keep an eye out for this. Certainly if parents have children who develop fever and some of these signs and symptoms, we urge them to contact their clinician and discuss it with them. With that, I will turn it over to my colleague, Infectious Disease Director, EHRESMANN.
Thank you, Ruth. I'd like to talk a little bit about Stay Safe Minnesota. As we anticipate the lifting of the stay-at-home order on Monday, I want to take the opportunity to remind you of the importance of social distancing. As you heard, we are continuing to see COVID-19 cases increase in Minnesota. And this makes it very important that as the governor loosens up some of the restrictions, that we continue to follow social distancing guidelines that we have been sharing with you. Maintain a distance of 6 feet between people, wear a cloth mask when you're out in public, and don't gather in groups of more than 10 while maintaining social distancing. It's really important that we are responsible with these community mitigation measures as we move into this new phase. I also want to address the question that has arisen of visiting friends and family in long-term care settings. the new guidance does not change the current limitation on visitors at long-term care settings. Visitor restrictions remain. The only exception is for compassionate care situations. Keep in mind that as licensed, registered, or certified providers of care, these facilities are required to be in compliance with current regulations, which prohibit visitors. And while we're talking about long-term care, I just wanted to clarify a couple of things that have come up since our conversation yesterday when we were talking about the ramp up in testing in our long-term care facilities. Our Minnesota National Guard is assisting with some of the testing. And I want to reiterate that the testing teams from the National Guard are made up of 10 members each with a combination of Army and Air National Guard personnel. The members that are conducting the testing are trained medical professionals, and they serve in duty assignments that are medical in nature. Many of these members work in the medical field in their civilian capacity as well, and they possess and maintain national certifications as emergency medical technicians. So I just wanted to reiterate that. I know there have been a lot of questions about that since we talked about it yesterday, and so just wanted to clarify that we are talking about National Guard members with a background in the medical field. And so just to conclude, we want you to enjoy the weather. We want you to look forward to Monday, but we want you to stay 6 feet apart, wear a cloth mask when you're outside of your home, and don't gather in groups any larger than 10. And with that, I'll turn it back to Mike Schomer.
Thanks, Chris. We'll open it up for questions now, and as we do, we'll ask that reporters limit their questions to one primary question and one on-topic follow-up. We'd also like to ask that you limit the number of questions from each outlet so we can get to as many outlets as possible. With that, operator, we are ready to take questions.
Thank you, and ladies and gentlemen, if you would like to ask a question, press star 1 on your telephone. For our first question, it's from Jeremy Alton from the Star Tribune. Your line's open.
Hi, I wanted to ask about the new dial measure of percent of cases with no known exposure. I wanted to get first a little more explanation on why that's a measure worth watching. Why do we care about that? Why is that going to make a difference, and why are we keeping an eye on it?
Great. Either Chris or Ruth. Chris, why don't you start, and then Ruth, if you have anything to add, please do.
Certainly. When we talk about someone who doesn't have a known exposure, we're assuming then that their exposure to COVID came about in a community setting. So if we know that there is an outbreak associated with a particular plant or a particular, say, long-term care facility, and we see additional cases in those facilities or those locations, we know that that transmission is linked to what's happening in the facility. When we hear about someone who says, you know, I don't know, I just went to the grocery store and I, don't know of any other exposures, that's significant because that's talking about what is circulating and happening in the broader community. And so we want to be attentive to that. It's not that we don't care about what happens in settings where we know there are cases or that we know that an outbreak is happening, but we also are attentive to what we're seeing circulating more broadly or diffusely in the community.
And my follow-up question, unless someone else has a comment on that, is about the 30% breakpoint you're using for your measurement. Is there any evidence of 30% being a meaningful statistic? And it's already above that, so what are you going to do to push that down? So if you can answer those two, that'd be great.
This is Ruth. It really is a sense of, especially when we're interviewing cases and trying to identify their high-risk contacts, when we come across cases then that don't have a contact, it tells us, as Chris articulated, that the virus is circulating and it means perhaps there's a higher level, that we've lost the epi-links, so to speak. So it is of concern. So with the attention to increase case interviews and contact tracing and all that, we do want to bring that measure down. We want to be able to control transmission within the community.
But why 30%? Is there any evidence to support that as a meaningful threshold?
That was our best guess, Jeremy. There is a lot we don't know, and so what we have said is we are coming up with metrics and measures, and we will refine them if it seems that that is not a great measure. But we want to diminish the number of cases that don't have this link. And so we thought that coming up with 30% or 33, a third, that was an amount that we felt we really, we wanted to be able to diminish the number of cases, and it's a balance between what is possible and what is aspirational.
Thank you.
For the next question, it's from Brian Arula from the Mankato Free Press. Your line's open.
Hi, thank you. Yesterday you provided an update on how many of the COVID-19 deaths in our state occurred among people with underlying health conditions. I'm wondering what have been some of the most common underlying health conditions among those who died? Are you noticing any more prevalent ones?
Chris, you want to start? And again,
Sure.
Please chime in if you have something to add.
There are certain conditions that we are asking about as we're doing interviews. So we're looking at underlying health conditions such as asthma, diabetes, chronic kidney, liver, or heart disease, and an immunocompromising condition. Those are all some of the things that we're looking at as it relates to underlying conditions. And I'll let Ruth add to that.
Yeah, I agree. And of course, another component when you look at the deaths, too, is that they tend to be older individuals. And often what we see is that there are people who have not just one medical condition, but they have multiple medical conditions.
Okay, thank you. And then as a follow-up, can you give us maybe an idea of how common these underlying health conditions are among Minnesotans, the overall population? Are we talking a fairly sizable percentage who might have one or more of these?
Yes, the estimates are, over 30% of the population, and I can dig that number up, but it's a fairly significant proportion of the population, and that's why, when we've heard questions, well, if you're seeing, deaths and hospitalizations and people with underlying health conditions, why don't we, just target things? Why was the whole state, in a shelter at home? And what we need to keep in mind is that this is a large portion of our population, and so we're working collectively. It's not just individuals who may reside in a long-term care setting. This is a big portion of our population, so our decision-making needs to take that into account.
And this is Ruth. I did just want to add a couple of other thoughts. I am not sure whether Chris mentioned obesity or not, but that also is a condition that we're seeing in many of the individuals who have severe disease. And I also want to point out, though, that there are, in fact, some hospitalized patients who are younger and who don't have underlying conditions. So certainly, if you are elderly and if you have underlying conditions, you're at a higher risk. But that doesn't mean that young, healthy people don't get severe disease. And so that is another reason why We have to take this virus seriously. Thank you.
And I'll just say that this is a study by the Henry Kaiser Family Foundation, but they found that about 34% of our population, 18 and older, had a high-risk underlying risk factor.
Okay, thank you.
For our next question, it's from Emily Havoc from Care 11. Your line is open.
Hey, team. Thanks for taking my question. Can you talk a little bit more, Dr. Linfield, about what you're seeing in children, and more specifically in Minnesota? And forgive me if I missed if you said specifically how many cases like this you've seen in the state, and what those cases look like in Minnesota.
So if I may ask you to come back next week and ask me the question, I will have more information because we just sent the health alert out today. So we have heard.
So you're going to be gathering.
We're going to be gathering the data, exactly. Thank you. But from other places, they have ranged from young children to adolescents. And so actually when we sent out the health alert, we asked people to look for people under the age of 21 who had that collection of symptoms.
Can I then rephrase my question a little bit and ask a different one? Could you speak a little bit about the connection with Kawasaki disease? This is something different but similar, or is it connected in some way, or do we not know?
Well, Kawasaki's disease is a condition that typically occurs in children under the age of 5, and it has very specific clinical criteria. Mucocutaneous lymph node syndrome is what it's also known as, and it's associated with having fever for 5 days and having red eyes and inflamed red cracking lips, a strawberry-like tongue because there's inflammation there, swollen hands and feet, and enlarged lymph nodes. And the reason why it is of importance is because those children can go on to develop coronary artery aneurysms. And people have found over time that treating them with intravenous immune globulin can and aspirin can prevent that complication or certainly attenuate it. Now, these children, some of them have presented like Kawasaki's. Many of them are older than the typical age range. Some of them have had components of toxic shock-like syndrome, which one can see in association with Staph aureus or streptococcus, where these bacteria produce certain toxins that result in shock and can result in rash and can result in injury to different organs. And so we are just trying to figure out what is going on here now that people are observing this. Initially, people thought, well, maybe they were just seeing an increase in cases, but the number of increase was much higher than people expected, and there was a recent article from a group in Italy that reported on it, people in the United Kingdom and France, and there are now over 100 children in New York, including 3 deaths, that have been associated with this syndrome.
Okay, thank you very much. And the name of the syndrome that you're specifically talking about is multisystem inflammatory syndrome, correct, in children?
That's right. People have used different names, so there may be a time period until the acronyms and the names settle. In New York, they were calling it Pediatric Multi-System Inflammatory Syndrome. We followed the CDC terminology, which is multi-system inflammatory syndrome in children. And I'm sorry, these are all complicated names, but I suspect that we will come up with an abbreviation soon.
Thank you, Doctor. Appreciate it.
Yeah.
For our next question, it's from Matt Sapik from the Minnesota Public. Your line is open.
Hi, this question is for Dr. LYNFIELD, and I just want to follow up a little bit on what Emily asked. I know you don't know a lot about this situation with children and these symptoms, but parents are hearing this and will likely and understandably be concerned. What is your message to parents and to children, given what you know and what little we know about how this is progressing here?
Ruth, are you on mute?
Oh, thank you so much. I was on mute. Thank you, Matt. Currently, the syndrome is thought to be rare, so we don't think it's common. We are learning more about it. Children have been treated with a number of therapies, including the therapies that are used to treat Kawasaki's disease. I did mention that there were 3 deaths, but that's unusual. Most of the children have gotten better, and we don't know 100% how and if and whether this syndrome is related to COVID-19. We think it probably is, and so doing some of the things that we are recommending to prevent infection with COVID-19 are useful things to do, such as what Chris discussed, the physical distancing, good hand hygiene, face covering if you're going outside, and again, trying to keep within household groups as much as you can. These sort of things we do think will be very helpful.
Okay, and to follow that up, and maybe this is a question for Chris or for Commissioner Malcolm, are there confirmed cases in Minnesota of COVID-19 in children? And if so, how many? And are you even really testing children?
I can start with that. And yes, we do have cases in children. We have had, 176 cases in children from birth to 5, 763 cases in 6 to 19. So we have had a number of cases, in the younger age group, and there have been hospitalizations, total of 27 from birth to 19, no deaths.
Okay, thank you.
For our next question, it's from Bill Warner from the Minnesota News. Your line is open.
Hi, thank you for taking the question, and this might be one for the Commissioner or maybe for Chris EHRESMANN. I know how much you are concentrating on long-term care facilities in Minnesota through increased testing and other measures. Do you have any way of knowing how well Minnesota is doing compared to other states in that area? In other words, maybe it'd be a brutal measure, but number of deaths per capita, and by capita I mean residents of nursing homes or long-term care facilities, that number at this point in the spread of the pandemic versus other states. Do you have any indication how well we're doing in that area relative to other states?
This is Commissioner Malcolm. That's a great question, and I think I had intended to dig deeper into that and haven't yet, so my apologies. But Chris may have something more on that, but we will come back to that question because it's of keen interest to us as well. I think we've talked before about just how important it is to make sure we're defining the universe the same way, and if it's only federally regulated skilled nursing facilities, or if it's a broader group of either what you would consider long-term care, or we've defined it even more broadly around congregate care settings. So it might be useful to try to cut that data several ways. I think the only thing that's required to be reported, as I understand it, and it's a fairly new requirement even from the Centers for Medicare and Medicaid Services. They just said within the last couple of weeks that skilled nursing facilities need to report cases and deaths to the CDC. So that's quite new. But it was only skilled nursing facilities. So my guess is that pretty soon we'll have at least nationally comparable figures on that. But a little harder to get your arms around assisted living and some of those other congregate settings. But thanks for reminding us of the question. We will dig further into it and give you a better answer next week, unless, Chris, you have anything you've already done on that score.
I don't. I do know that we, as you mentioned, we are quite comprehensive in what we're considering to be congregate care settings, so group homes and other residential treatment facilities. And my guess is that other states are not doing that, but we will follow up.
I appreciate that, and I understand that this probably would to not only compare apples to apples, that you'd have to have the same group of long-term care facilities, in other words, all skilled nursing compared to all skilled nursing or whatever. I understand that, and that also it would depend on at what point in the progression of the pandemic in each of the states you're comparing it, right? But is it possible to include some sort of an indicator when you get your hands around one that's, apples to apples and reasonably representative, to include that on the dashboard, so folks, so even Minnesotans are able, who have loved ones in long-term care facilities, are able to see, what kind of progress are we making, at least by some indicator.
Thanks for that suggestion, Bill. We will certainly consider what might be useful to add to the dashboard. This is a little bit of a tangent, but I think it's related and it kind of illustrates the challenge and the importance of being clear about our definitions and what's counted and what's not. I don't recall that we've talked about it a lot on these calls, but we do have we get some feedback of varying kinds from long-term care facilities, from families, from physicians, from legislators, asking, why do we count every person who's had a positive COVID test as a COVID death? And you may have heard this distinction some are drawing. Do we say somebody died of COVID disease or with COVID disease if they already had a number of other conditions and potentially were in end-of-life situations, which, just given the advanced age of many of our folks in these long-term care facilities, not all, certainly there are younger people with disabilities and other conditions as well, of course. But the number of folks who have advanced heart disease or advanced cancer, who get COVID, and did they really die from COVID or with COVID? And that's a very interesting and important question, I think. But there too, I think it'd be good to compare notes and see if there's consistency or not consistency across the states in how they're handling that. We've taken the position that a more complete count, or that any time something has been a case has been confirmed through laboratory testing, that we do count that as a COVID death. But we understand also some of the questions and concerns that physicians or facilities may have about that characterization.
I guess what you're talking about there, Commissioner, would also play into the numbers of just the comparisons of Minnesota's rate of, or the percentage of Minnesota's COVID deaths that are in long-term care facilities. That plays out in there, too, I would.
Yeah, exactly.
Okay, yeah, thank you very much.
For the next question, it's from Sue Kraft from Mahomet Pioneer. Your line is open.
Thank you, Commissioner, for taking my question. We're up here in northwest Minnesota and Lakes Country. When are you anticipating the number of COVID-19 cases will increase or reach a peak for this wave in northwest Minnesota, Lakes Country? And at that time, what resources are you planning to send up here to help us deal with that, since we don't have the same resources that you have down in the cities? Thank you.
Well, thank you, and we certainly understand the interest in regional projections. We don't, and I will certainly welcome whatever contributions Chris or Ruth might have to your question, but we don't have any kind of geographically specific projections of what we think the peak is likely to be at a county level, for example, but we are kind of looking at a statewide peak. And we also, I think we've mentioned on prior calls, we've got a system. There are 8 regional healthcare preparedness coalitions around the state that cover all of our state's geography. And we have got good information on healthcare capacity in all of those regions, how many acute care hospital beds they have, how many intensive care unit beds, how many ventilators. We've got a fairly good level of detail on what is everyone's situation around the whole state. And the plan, certainly has been to support the facilities to be doing their own preparedness planning and to be increasing capacity where they can, but also to have a system where, and this has already been stood up, already exists, so providers around the state can call a 24/7 resource number if they don't have the capacity they need locally to help get their patients to the care that is needed. So we're taking a statewide approach to making sure that people can get the care they need.
Thank you.
For the next one, it's from Gage Curtin from the KC News Now. Your line's open.
Hi, yes, good afternoon, Commissioner. Thank you for taking this question. A majority of our viewers are wondering, with the potential reopening of bars and restaurants approaching, what are the guidelines the MDH is considering putting in place, and what are these going to look like for these establishments?
We're working on that literally over the next days. I think in the governor's announcement the other night, he said he was directing several agencies to work together to come up with guidance that would help sectors like like restaurants and other places of public accommodation, as his order refers to them, so that they can understand what would be required in an eventual reopening. So we are just working on that now. There are likely to be things that focus heavily on social distancing, perhaps requiring restaurants not to be open above a certain capacity or to control the number of patrons in the facility at any one time. Still want to emphasize the value of curbside pickup or delivery options. There would be recommendations certainly around screening of the health of staff and appropriate source control protections for staff as well as patrons. So all that guidance will be definitely out and available in advance of any potential reopening dates.
Okay, thank you.
For the next one, it's from Kelly Bush from the Duluth News. Your line's open.
Hi. How do you expect Wisconsin's relaxation of stay-at-home orders to impact case numbers here in Minnesota?
Well, it's a great question, and kind of illustrates some of the challenge of having state-by-state variation when we know that folks do go across the border with some regularity, particularly with our immediate neighbor states. So it is very possible that a significant change, kind of a rapid expansion of social interactions in Wisconsin could have some impact, particularly in border communities, but possibly beyond that. So that's just one of the things that makes measuring the impact, as our numbers change, what's driving what, is going to just get to be a kind of a tougher and tougher challenge to be able to really say with confidence, well, the Wisconsin opening did this, and the last round of business openings did that. In Minnesota, the relaxation of the social gatherings guidance did X. We'd love to be able to get that granular, but unfortunately, I don't think we're going to ever have the ability to get that precise about what's driving what. But it's a very logical question, and quite honestly, we do expect it will affect us.
Thank you. So, is there anything you're changing or preparing for in relation to Wisconsin's changes?
Ruth or Chris, I invite you to comment if you have anything to say there. I would have to say at the level of macro statewide planning, no, we've not factored that in any specific way. But Ruth or Chris, you might have some ideas about what you might be looking for in the data.
Well, yeah, we'll be monitoring what's happening in Minnesota, and in particular, along the border. So if we start to see increase in cases along our shared border, those will be things that we'll be looking for.
Great, thank you.
For our last question, it's from Phil Miller from the Star Tribune. Your line is open.
Hi, thank you, Commissioner. The governor on Monday spoke with the commissioner of baseball about resuming or starting the season in Minneapolis in early July. Part of the plan that baseball envisions includes frequent, if not daily, testing of everyone involved, probably a couple hundred people in and around each team. You've spoken about testing capacity and how Minnesota's kind of gotten ahead of it. Are there any concerns about that frequency of testing being required, or any concerns on your part in general about the notion of baseball starting in 6 weeks?
Well, thanks. I do think that the interest that various employers and sectors have in testing and testing frequently is certainly something we need to continue to build into our forecast about how much testing we're going to need and of what type and with what frequency. I think we've talked before about the fact that the science is still emerging on what testing is of most value and when. So I can't really comment on the volume of testing that might be indicated for the twins or anyone else. Certainly we all, wouldn't say we all, but I sure miss having that as a recreational thing to look forward to. But the thing that I guess I have to say with my understanding is that the idea would be to play not in front of large crowds, but still to be traveling among the various stadiums, so that teams would be obviously moving all over the country to play their schedules, which then that's just not something that we're seeing the rest of the economy prepared to do, or many citizens traveling around. And we're still really, I think, even from a national perspective, emphasizing, minimizing travel while case counts are still rising across the country. So that I would have a little bit of concern just about that. above and beyond sort of what it might require in terms of support from a testing volume standpoint. But, I think that a whole testing regimen, testing industry is continuing to grow, so I expect that employers will have access to some of the testing that they will need. But again, we're going to keep reinforcing. We want to make sure that it's high-quality testing and that the results are actually meaningful. Sorry for that long answer.
No, I appreciate that. And then follow-up, you mentioned that it envisions playing without fans in the stands for as long as is necessary. Is there any reason to believe that that would not need to continue throughout the entire season, which would last probably into October here in Minnesota?
Right, and I think we haven't had enough discussion yet, and will, I trust, in coming weeks and months about what we need to be prepared for in terms of subsequent waves, potentially of the virus coming in waves as more and more relaxation of restrictions happens around the country, but also just the seasonal pattern, as well as the impact of loosening restrictions when still only a small part of the population has been exposed to the virus. There's a good reason to assume, and I think the governor has said, we need to build our planning around living with this for quite some period of time, whether that's in a series of waves or a more consistent pattern. So I sadly don't envision seeing full stadiums anytime this year.
Thank you, Commissioner. Appreciate it.
Okay, I think that's all the time we have for today. I do want to thank our speakers and the reporters on the call. If you had a question we were not able to address, please feel free to reach out to our office by calling 651-201-4989. Have a good day, and we will talk with you again Monday.
Find more local news stories at ccxmedia.org and follow us on social media.